Mechanism of organ dysfunction in intra-abdominal hypertension, IAH. Intra-abdominal hypertension, IAH, is defined as a sustained increase in intra-abdominal pressure, IAP, above 12 mm Hg. When severe, it can progress to abdominal compartment syndrome, ACS, causing multi-organ dysfunction and failure. This condition is often secondary to abdominal trauma, surgery, severe sepsis, or massive fluid resuscitation. Elevated IAP impacts multiple organ systems through mechanical compression, altered perfusion, and systemic inflammatory responses. 1. Cardiovascular system. Decreased venous return. Elevated IAP compresses the inferior vena cava, IVC, reducing venous return to the heart. This leads to decreased preload and cardiac output. Increased afterload. Elevated diaphragm pressure increases thoracic pressure, impeding cardiac filling and increasing systemic vascular resistance. Hypotension and shock. Reduced cardiac output compromises organ perfusion, exacerbating hypotension and leading to systemic shock in severe cases. 2. Respiratory system. Reduced lung volumes. Increased IAP elevates the diaphragm, reducing functional residual capacity, FRC, and tidal volume. Increased airway pressures. Compression of thoracic structures increases airway pressures, causing difficulties in mechanical ventilation. Hypoxemia and hypercapnia. Impaired ventilation perfusion matching results in hypoxemia and hypercapnia, potentially leading to respiratory failure. 3. Renal system. Reduced renal perfusion. Direct compression of renal vasculature and parenchyma reduces renal blood flow and glomerular filtration rate, GFR. Acute kidney injury, AKI. Decreased renal perfusion and increased venous congestion lead to oliguria and AKI, often associated with fluid overload. 4. Gastrointestinal system. Mesenteric ischemia. Elevated IAP compromises splanchnic blood flow, leading to ischemia and mucosal damage. Bacterial translocation. Ischemia and mucosal injury can disrupt the intestinal barrier, allowing bacterial translocation and increasing the risk of sepsis. Gut paralysis. Impaired perfusion and ischemia may lead to ileus or bowel infarction in severe cases. 5. Neurological system. Increased intracranial pressure. Elevated IAP raises intrathoracic pressure, impairing venous drainage from the brain and increasing ICP. Decreased cerebral perfusion. Elevated ICP reduces cerebral perfusion pressure, causing cerebral ischemia and potential neurological dysfunction. 6. Hepatic system. Reduced hepatic perfusion. Increased IAP compromises portal venous and hepatic arterial blood flow, reducing liver function. Impaired detoxification. Decreased hepatic perfusion can lead to accumulation of toxins, exacerbating systemic inflammation and multi-organ dysfunction. 7. Systemic inflammatory response. Cytokine release. Tissue ischemia and cellular injury from IAH can trigger a systemic inflammatory response, further exacerbating organ dysfunction. Edema and capillary leak. Inflammatory mediators increase capillary permeability, contributing to third spacing of fluids and worsening organ compression. Summary of mechanisms. Intra-abdominal hypertension leads to organ dysfunction, primarily through 1. Mechanical compression. Direct pressure on organs and vessels reduces blood flow and impairs function. 2. Perfusion abnormalities. Reduced cardiac output and organ-specific blood flow lead to ischemia and hypoxia. 3. Systemic effects. Elevated pressures propagate systemic dysfunction, triggering inflammatory cascades and worsening multi-organ failure. Effective management of IAH requires early detection and targeted interventions such as decompressive laparotomy, fluid optimization, and organ support to mitigate these effects.